Welcome to Screening for Disease. This lecture is part of Principles of Epidemiology offered for the master's program at Montana Tech. My name is Theresa Stack. I'm an assistant professor at Montana Tech, and I will be delivering this learning unit to you. To understand how a disease is transmitted and develops, and to provide appropriate and effective health care, it is very necessary to distinguish between people in a population who have a disease and people in a population who don't. This learning unit focuses specifically on screening tests for public and occupational health, how to evaluate the effectiveness of a test, and interpret the results of a test. It does not get into designing test procedures. It also introduces to you different levels of care and certain types of interventions in which screening tests can be used. Screening is the application of a test to detect a potential disease or condition in a person who has no known signs of that disease or the condition, or who has some known signs and you've already developed a baseline. For example, it can be used preventative to prevent further hearing loss, or it can be used protectively to detect HIV in contaminated blood. Patients who have symptoms or signs of the disease would go to see a physician and undergo a workup for the disease to detect the presence or the absence. This is not a screening test. It's a very important distinction between what a screening test is and what a screening test is not. A screening test is used in individuals who have no known signs or symptoms of the disease, although of course they may have risk factors. An example would be a 55-year-old male complaining of chest pains, or a woman presenting at a physician's office with a lump in their breast. This would not be the example of when you would use a screening test. Instead, you would do some kind of physical workup to detect the presence or the absence of a disease. The screening period has already passed. This slide shows the distinction between a screening test and a diagnostic test. A screening test is on people who appear healthy, where a diagnostic test is on people with some kind of signs and symptoms. A screening test is best applied to large groups of people as opposed to individual patients. Screening tests have a criteria or a cutoff point in which you will move forward into further tests or not move forward. Diagnostic tests are based on lab findings as well as the evaluations of signs and symptoms. For screening tests to be effective and widely accepted, there should be some basis for treatment, as if I screen you and find out that you have a disease, I can actually treat you. They need to be not very expensive and not too intrusive. Usually the initiation of a screening test comes from the investigator because they think people may be at risk, versus the initiation of a diagnostic test typically comes from a patient who has some kind of signs and symptoms. In using a test to distinguish between individuals with normal or abnormal results, it is important to understand how characteristics of the abnormal and normal results are distributed in the population. Sometimes, as you see with the exposure to tuberculosis and a bimodal curve, there is a clear distinction between individuals who were previously exposed to or had prior experience with tuberculosis, those people with hard masses larger than 20 millimeters, and those people who had hard masses less than 20 millimeters and did not have any prior experience with tuberculosis. It's easier for researchers to set a cutoff point versus the graph of blood pressure and the number of people with that certain blood pressure. There is definitely a gray zone in between where we should set our cutoff point. What determines that a certain characteristic is abnormal versus normal? it's very difficult to choose where that cutoff point is, and there could be a variety of distributions throughout a population. So when you're taking a test such as a blood pressure test, and the cutoff is a hard number, such as 110 millimeters Hg, that is set by doing other research studies besides just looking at blood pressure and the number of people who could develop some type of cardiovascular disease. So it's not always easy to determine what those cutoff points are or how good the test is separating populations of people with the disease, and that's our true positives, which looks at our sensitivity, and those without the disease, which are our true negatives, and that looks at our specificity. So these terms about reliability and validity we'll use over and over again. We'll begin our talk with validity, and that will occur after we talk a little bit more about the stages of care. Screening programs are often used in occupational settings to monitor individuals for the development of certain conditions or the progression of certain conditions. In practice, such programs can be useful for identifying disease early and possibly increasing the chances for a successful outcome, or monitoring work-related disease to improve on or enact a worker protection method, such as adding hearing protection or a respiratory protection program. Screening tests can be used at different levels of care: primary, secondary, and tertiary. At the primary level of care, we're trying to prevent the disease from occurring. For example, a screening test to measure blood pressure to see if you're at risk of developing some disease in which an increase in blood pressure is noted as a risk factor. The most widely used level of care for screening tests is the secondary, and that is to reduce the impact of disease on a population or a person. So for example, mammogram screening to identify patients in an early stages of breast cancer. So they don't actually have the signs and symptoms, but you do the screening anyways. If you went through and you had manipulations of your breast by your physician, that can be considered primary screening. And then they found a lump and they sent you for secondary screening. And a mammogram can be seen as secondary screening or primary, although you're supposed to be doing the primary on your own. Another example would be pap smears to identify patients with the possibility of mutagenic cells, audiometry testing to identify a threshold shift. That's where, of course, you'd have to have a background, or temperature screening before boarding an airplane leaving South Africa to see if you have any type of infection. And finally, screening tests can be used to improve the quality of life or certain outcomes related to a disease in which a person already has, such as bone screening in conjunction with certain types of cancers to prevent pathological fractures. Some additional goals of screening programs could be exclusionary, such as in the military. For example, if you've had a broken collarbone, you're not allowed to join the military. For sports events or fit for duty testing, it could be to protect society as a whole, such as tuberculosis testing, eye testing for people getting their driver's license or pilot testing, drug screening for CDL drivers. For the prevention and control of disease such as diabetes, sickle cell anemia disease, hearing loss, or lead poisoning, and surveillance programs. So example would be the HIV status in high-risk groups, hepatitis B among HIV drug users. So screening can be used in lots of different instances, and we're going to talk about screening tests in general and what they actually mean. I think you'll find it quite interesting once you go through and hear the material. So is a disease appropriate for screening? Well, there would need to be the prevalence of the disease in the population to warrant testing. Otherwise, we would do a whole bunch of screening and not find much disease. Treatment which would begin before the symptoms develop, should be more beneficial than intervening after the symptoms develop. So these are two particularly important parameters that are typically met when designing a screening program, as well as the test itself needs to be non-intrusive to the individual, cheap, easy to administer, as well as acceptable to the population, something that you would be okay with doing given the benefit of the disease. Some examples of occupational screening programs: audiology, fit for duty, vision testing, the risk of glaucoma, spirometry, electrocardiogram, chest x-rays, blood and urine tests, drug and alcohol testing, personality tests, and background tests. And there's probably some more that I have missed, but this is just a sampling. Whew, that's a lot of testing. There are two underlying principles of a screening test to see how well the screening test itself detects the presence and the absence of the disease. And this has to do with the validity, the ability to predict who has the disease and who does not. Is it a valid test? A test could measure something, but it may not measure the right thing. So there's two terms that are used: sensitivity, the ability of the test to correctly identify those that have the disease. A highly sensitive test has very few false negatives. And the specificity of a test, the ability of the test to correctly identify those who do not have the disease. A test that is highly specific is a test with very few false positives. There is a link here as well as on the Moodle page which describes sensitivity and specificity, so you can see some of the issues of putting somebody in the wrong category. For example, I would never want to have a false positive with a pregnancy test. A false negative may be better, because over time you'll figure it out. We have a screening test of some form, and we want to see how valid the test is in determining whether a population has a disease or does not have a disease. So if we take a look at our table, now would be a good time to start thinking about this and filling it in. So if I truly have the disease and the test comes back positive, that would be a true positive. If I truly do not have the disease and the disease comes back negative, that would be a true negative. Now, if I do not have the disease, but it comes back positive, so I am not pregnant, but there's a little plus there on the p-test, then this would be a false positive. And then if I do not have the disease, although being pregnant isn't a disease, of course, but you understand the analogy here, I hope. But if I do not have the disease and the test comes back negative, if I truly do not have the disease and the disease comes back negative, then that would be my true negative, right? So we have true positives, you have the disease and the test comes back positive, and then you have true negatives. You do not have the disease and the test comes back negative, and then you have something in between. So go ahead and figure out where you think you'd put your TPs and your TNs, and we'll take a look at that on the next slide. So let's take a look at our chart and see how you did. You have the disease and the test accurately says so. It can find that disease in the population. That would be your true positive. Versus you do have the disease but the test comes back negative, that would be your false negatives. Now, if you don't have the disease, but the test comes back positive, that's your false positives. And then your true negatives is ultimately what you're looking for in specificity, and that is you do not have the disease and the test tells you so. So you have true positives and true negatives, and those are our numerators versus our denominators, which is the sum of our disease columns. And this is just another way to describe the same information. And what you see at the bottom are also your predictive values, positive and negative, which we will talk about a little bit later. Right now, we're just looking at our disease and our non-disease columns, our sensitivity, which is our true positives, and your specificity, which is your true negatives. Now let's look at sensitivity and specificity alone. So we're looking at sensitivity, which is your true positive value. So you have 100 people who absolutely have AIDS, and we're trying to develop a new screening test. The new screening test finds 90 of those people positives, which would be our true positives. They have AIDS, and the test says so. But 10 of them come back negatives. These are our false positives. So the sensitivity of the test is 90%. If you test positive, you're 90% certain that the disease is present, given the test. Now let's look at sensitivity and specificity alone. So we're looking at sensitivity, which is your true positive value. So you have 100 people who absolutely have AIDS, and we're trying to develop a new screening test. The new screening test finds 90 of those people positives, which would be our true positives. They have AIDS, and the test says so. But 10 of them come back negatives. These are our false positives. So the sensitivity of the test is 90%. If you test positive, you're 90% certain that the disease is present, given the test. Now let's take a look at specificity. We have 100 people who do not have AIDS, so their disease state is negative. The new HIV test says that 90 of these people were positive, so that would be our false positives, and 10 of these people were negatives. That would be our true negatives. So what is our specificity of the test? Let's do some math. Well, we have 90 false positives and 10 true negatives, and we take our test negative, our true negatives, and we put it under the total people who do not have the disease. Their disease state is negative, and we find out that the specificity is only 1%. This test is not very specific, meaning that there's a whole bunch of false positives. We probably wouldn't want to use this test because secondary screening for HIV would cause a lot of trauma to a person that didn't necessarily need to be there. We may find a better test or a test that's used in combination with something else. So how would we interpret the results? The first test was sensitive. 90% of the people with the disease were accurately identified. We still missed some people. The second test was not very specific. 1% of the people without the disease were identified. So if these were looking at two different tests with different sensitivity and a different specificity. Now let's look at one test and evaluate its sensitivity and its specificity together. So how would you fill in the table? We have data from 2,000 people. 1,000 of them have AIDS and 1,000 of them do not. So we already know our totals about our true disease states. The test found 970 people to be positive, and they later developed AIDS. So that means those are our true positives. The test found 998 people who did not develop AIDS and who tested negative. So those would be our true negatives. And we can fill in the other numbers and do some math. And let's see how we calculate our sensitivity. Sensitivity are our true positives, versus our specificity, which is our true negatives. Let's evaluate this test. So 2,000 people, 1,000 have AIDS, 1,000 do not. We are starting to build our table. 970 people are our true positives. They tested positives and they later developed AIDS. 998 people would be our true negatives. They tested negative and they later did not develop AIDS. So to calculate our sensitivity, we take our true positives, 970, and we divide it by our total true disease state yes, which would be 1,000. And we see that our test is 97% sensitive. But we still missed 30 people who had the disease but tested negative. Now let's look at our specificity. So we take our 998 people who tested negative and did not have the disease, and we divide this over our total population, and we find out that 99.9% of the people were identified correctly as not having the disease. But we missed 2 people in our test. So this test is very specific, meaning that if you get a negative result, you can be quite confident that you don't actually have the disease, or that the test correctly identifies you as so. Sensitivity and specificity look at the validity of the test itself. So for this particular test, it was 97% sensitive, which means that 3% of the people were missed. They had a negative test, but they actually had the life-changing disease of AIDS. But only 0.2% of the people who took the test went on for unnecessary secondary screening. So the test is very specific. You may trust a negative result more so than a positive result with this particular test, because the specificity is more accurate. Sensitivity and specificity have to do with the validity of the test itself and not the predictive value of the test. And another way to look at the data so that you remember it and see where it all fits in parts of the pie, pieces of the puzzle. And we'll expand on this when we look at the predictive value, which is to come. If you need a refresher on validity and accuracy, there's a link on Moodle which you can select, and it'll help to describe validity and accuracy, because sometimes they get to be confusing terms. Sensitivity and specificity deal with the validity of the test to determine whether the disease is present or not. If we're trying to determine proportionality, that is the percentage of the population that actually has the disease if the test comes back positive, we call this accuracy in the screening world. So there's a difference between validity and accuracy, precision versus repeatability inside of a population. Sensitivity and specificity are characteristics of the test where predictive value positive and predictive value negative are characteristics of the prevalence of the disease in the population, as well as the test's ability to accurately determine whether that disease is there or not. Separate concepts, very closely related. I think the YouTube link really helps with this one. And the link is here for you. Predictive value allows you to predict the test given the results. That's the probability of a positive result, meaning that I actually have the disease or not, versus the sensitivity or specificity of the test to determine whether the disease is present or absent. This is the probability of a positive test, meaning that I actually have the disease, or that the disease is present in the population. It relies heavily on the rate of false positives, and therefore the specificity of a test, as well as the prevalence of that disease in a population. If it isn't very prevalent, it'll be quite hard for a test to be able to detect at small values, right? Because we're looking for that big what, that big denominator in the basement. So specificity and sensitivity look at your columns, disease versus not disease, and predictive value positive and negative look at your rows. How well did the test determine positive versus negative? Test values versus disease values. And you can see that the math looks very similar. So let's take a look at what predictive value positive actually tells us, the likelihood that the disease is present if I have a positive test. Predictive value positive is true positives over true positives plus false positives, right? So false positives are the ones that we missed. So how many truths did we get in all of our tests? So if 60 patients with positive stress tests, 10 of them later developed coronary heart disease. So what is our predictive value positive? Well, we take our 10 and we put that over our 60, and we find out that our predictive value positive is 16%. This is the probability that a positive test means that the person actually has the disease. This test doesn't have a very good predictive value positive, but it may be a useful test. It may have a very good predictive value negative. Might be used for something else. So let's continue to fill in our data. Now we have 60 other patients whose tests came back negative. 10 of them later developed coronary heart disease. So that means that we had 10 false positives and 50 true negatives, right? Because these 60 patients had a negative test, 10 of them later had coronary heart disease. If they had a negative test and it was later found that they had coronary heart disease, these would be considered false positives. So the predictive value negative for this test was a little bit better. We have our 50 true negatives, or truth, divided by the total people who tested negative, that's our true negatives plus our false positives, which gave us an 87% probability, given a negative test, that the person does not have the disease. So this test would be better at determining whether you do not have the disease versus whether you do have the disease. And as you can see, those are completely mutually exclusive, as are sensitivity and specificity to some degree. It's based on not only the test, but the prevalence of the disease within a population, right? The test itself and the probability that people have the disease. The test itself, specificity and sensitivity, and the prevalence of disease in the population. Positive value. So all this information used together will help physicians decide and interpret your results, and maybe will help you interpret your results, or help you assist people in an occupational or professional setting in interpreting their results. So taking a look at this test all together, does the test accurately determine whether somebody has the disease or not? It does a little better in determining whether you do not have the disease, right? It was 97% specific. And that coincides with the precision. Does a positive or does a negative test mean that I do not have the disease? 83% probability that if I have a negative test, I do not have the disease. The specificity and the predictive value negative would, of course, go together. So we have to balance these out in the interpretation of our data. So this slide is a good reference for looking at specificity and sensitivity, which are your columns, versus predictive value positive and negative, which are your rows. So we have a in-class example, and since you're there listening to this someplace other than the class, see if you can calculate sensitivity, specificity, predictive value, positive, negative, and then accuracy will be shown on the following slide. And I hope you enjoyed this lecture material. I think the text does a really good job of explaining it, and it certainly broadens your understanding of screening tests, how they're used before diagnostic tests, and what the value of them is within our profession. Have a wonderful day.